we do have Madeline Metcalf, who has recently rejoined us at Gemini, who is going to be presenting about IDEAS-AUD, which she'll tell you all about.
Perfect. Okay.
Just about to start and in Tanzania. So I'm not going to steal your thunder because you're introducing us to the topic, but welcome, Maddie. Take it away.
Perfect. Thanks, Ashley. Yeah, so as Ashley said, I'm going to be presenting about the IDEAS AUD project, which is focused on adapting a telehealth intervention for suicide prevention among alcohol use disorder patients in Tanzania. This was just recently funded through an R34, and it's going to be starting soon. A quick presentation overview. I won't really go through this too much, but you can see kind of where we're headed. So a little bit about what we know of background about alcohol use disorder and suicide, both globally and then within Tanzania. So globally, we know that alcohol it causes about 3.3 million deaths per year and is a leading contributor to global mortality, as well as is responsible for about 100 million disability adjusted life years per year as well. We also know that about 23% of Tanzanians meet alcohol use disorder criteria, which is about 4 times more than the global average, and that folks with alcohol use disorder have a higher lifetime suicide risk of about more than 10%. And when we think about suicide behavior in Tanzania, we know that suicidal behavior and ideation is criminalized. So we think about problems potentially with severe underreporting and stigma. However, some of our previous work, informative work done by both Dr. Staten and Dr. Knettel, have found that about 7% of AUD patients presenting for care at the KCMC emergency department reported suicidal thoughts, which is about 2.5% of the local general population. And that no standard alcohol use disorder and suicide co-treatment protocol currently exists within Tanzania. We also know that there is a pretty severe treatment gap when we think about what treatment resources are available within the country. So Tanzania has about 55 psychiatrists and psychologists for over 65 million people. And for KCMC specifically, there's 3 psychiatrists who serve all of northern Tanzania. We also, Dr. Knettel and his team have done a scoping review of the literature and found 11 counseling studies for suicide prevention across all of Africa. However, none of those studies were conducted in Tanzania. And then, as I mentioned, we know that suicidal behavior is criminalized under Tanzanian law. And previous work from the Gemini team has found that emergency department visits are really often the first and only healthcare contact for people with alcohol use disorder, representing kind of an important point of care entry into the healthcare system. However, we know that emergency department visits and care can be really expensive, and about 70 to 80% of emergency department patients in Tanzania face financial catastrophe after treatment costs. So moving on to a little bit about what the intervention is. So this is an intervention to reduce suicidal ideation by fostering emotional health, reducing alcohol-related harm, building social support, and addressing social determinants of health for the AUD population. And so that's where we get the IDEAS AUD. This was built off of some of Dr. Knettel's formative work with his Ideas for Hope intervention that was looking at suicide prevention among HIV patients at KCMC, and as well as Dr. Staten's work with the PPK. And so digging in a little bit to what kind of the framework is for the intervention. So we have this kind of 4 pillars framework, and we can think about it as a house with this formative kind of foundation of the house, thinking about personal values, reasons for living, and then some of these pillars of the intervention itself. So the first pillar will be reducing alcohol-related harms, thinking about how we address triggers, consequences of heavy alcohol use, and then building healthier coping alternatives. The second pillar, thinking about building social support, how we can leverage family and community, reduce isolation that fuels both alcohol use disorder and suicidal ideation. The third pillar being enhancing emotional health. So they plan to use cognitive behavioral therapy informed mood management and to address feelings of hopelessness, shame, or negative thought patterns around suicidal ideations or their alcohol use disorder. And then this last pillar being addressing social determinants of alcohol use disorder and suicide risk. So thinking about problem solving and breaking things down into much more manageable portions to address social determinants of health. And then finally ending with this kind of roof and how we think about safety planning of managing potential suicidal thoughts, creating actionable safety and structured plans to and so thinking about the telehealth sessions, so the folks will be kind of enrolled into the study, and upon enrollment, and we'll talk about enrollment, I think, in the next slide, but there's going to be 3 sessions to the main intervention. And so the first session is really upon enrollment, which where we think about this motivational interviewing, enhanced safety planning. And so this is the first time for the counselors at KCMC to meet with the patient. They're going to introduce the 4 pillars, explore alcohol use disorder and suicide history, thinking about completing this safety plan, and then identify some of those foundational personal values and reasons for living. And this was all informed by an evidence-based kind of conceptual framework of the MI Safe Cope, which was initially developed for use in high-income countries. And Dr. Knettel and his team adapted this work as part of their Ideas for Hope intervention. And so that's where some of this framework is coming from. Participants will then complete a second session on day 7 that's really focused on the problem solving and stigma reduction aspect of the intervention. And so this will be done through storytelling, kind of counselors walking through a story with participants to think about, kind of this like someone who may be in a similar situation of having suicidal thoughts, and someone who's drinking, and kind of some of these potential challenges or experiences that this person in the story might have, just to help normalize kind of those help-seeking behaviors. And then this is where the cognitive behavioral therapy also really comes in to think about how we restructure those behaviors. And then, as I mentioned before, there's going to be problem-solving components for social determinants of health that really involves taking these large, kind of overall comprehensive problems and breaking them down into smaller, more manageable pieces that have an action plan for being able to move forward. And then the final session is going to be on day 14, which is really developing this structured action plan, reviewing kind of this progress on the 4 pillars, using motivational interviewing again to reinforce those personal values and hope for the future, and then developing these session summaries with optional booster sessions available after. And so this is a little bit more about the participant screening and enrollment. And I wanted to put this kind of intervention assignment slide in here to think about how folks presented for care at the emergency department will be enrolled in either the IDEAS, AUD, or into the PPK intervention. And so you can see the folks who will come in to the emergency department, they'll get initially screened for alcohol use disorder. And then as part of the enrollment to the study, they'll be screened if they have if they screen positive for harmful alcohol use, then with the audit, so an audit score greater than 8, they will then also complete the suicide intent screening, which is the Columbia Suicide Severity Rating Scale, and really just looking at whether there's an item on there that measures whether someone has had suicidal thoughts in the last 30 days. And if they screen positive for both of those, so for alcohol use disorder and suicidal intent, then they will be enrolled into the IDEAS-AUD. Whereas if someone only screens positive for alcohol use disorder, then they will be enrolled into the PPK study. And so there's three specific games kind of when we think about the intervention and implementing the project. So the first one is really to identify these drivers of suicide risk. The second one being to adapt the intervention with a community coalition. So to adapt kind of this existing formative work and this existing framework to the AUD population using both CFIR as well as user-centered design principles and co-design sessions. And then the final aim will be to actually pilot test the intervention. And so digging into a little bit more of the aims specifically, this first one will be really focused on qualitative in-depth interviews. And so folks will complete interviews with at least 16 patients with both alcohol use disorder and suicidal ideation. 8 treatment supporters, so families or partners of patients, 8 healthcare workers, who are folks who are actually working at KCMC, and then a handful of healthcare administrators as well. And the goal of the qualitative interviews is really just to gain a sense of what are some of these drivers behind both alcohol use disorder and suicidal ideation and this kind of comorbidity of disease among the population, and to think about how that informs the intervention itself and future work at KCMC. And then interviews will be coded using a thematic analysis approach that will be grounded in a grounded theory framework as well to support both the transparency and reproducibility of the codes. And so the second component is this where we dive into the community guided intervention adaptation. And so this really involves 2 co-design sessions with the community coalition, which will consist of patients, family, healthcare workers, and admins, and will be guided by the consolidated framework for implementation. I'm blanking on the CFIR acronym right now, 2.0. And then we'll keep kind of look at 2 elements of the intervention. And so core elements are what we want to make sure is preserved within the intervention. So this is work that has come from both the MI Safe Cope kind of foundational framework, as well as the Ideas for Hope intervention that has already been done at KCMC. And so you can see those things there. The telehealth video delivery. They've done a lot of work within the psychiatry department at KCMC to develop the telehealth hub. And so wanting to ensure that, keeping that 4 pillars framework, and then having the intervention delivered by local diploma level nurse counselors. And then there's this session over here, which is more of this adaptable or community refined components of the intervention, which will really be guided by CFIR and as well as these co-design sessions. And so thinking about things like session timing, length, spacing, whether additional cultural and linguistic adaptation needs to happen to the Swahili context, those local referral pathways and some of the provider logistics, and then additional counselor training and fidelity tools. And so here we can see kind of some of these CFIR domains and constructs that have been informing the development of IDEAS-AUD, and that will the co-design sessions will help address. And so really in one of the co-design sessions is the community coalition will walk through kind of like the experience of a patient and to experience the intervention as a patient would, to be able to provide feedback that would help the potential refinement and restructuring of the intervention itself. Really what the co-design sessions is wanting to focus on is kind of these adaptable periphery components, which refers back to kind of what we looked at in the last slide about some of these logistics of screening the intervention details, and thinking about the length, number, format, and how the intervention is actually delivered. And then finally, the third aim is to actually pilot the study. And so we know the enrollment criteria of folks here. So as we mentioned, they have to have an audit score of greater than or equal to 8, have actual suicidal thoughts in the past 30 days, and then be adults, fluent in Swahili or English, and then medically stable upon enrollment. And then we walked through this a little bit as well, but as a refresher on some of the participant flow. So mostly after the first session, there'll be a 3-month follow-up survey, and that 50% hopefully of participants will complete an in-depth interview to provide feedback on the intervention as well. And then I won't spend too much time here, but here's some of the key measures of instruments that will be used within data collection, and that instruments that have been adapted or validated in Swahili and within the Tanzanian context will be used as much as possible or when available. And you can see kind of the time point of when folks will complete all of these instruments as well, at both baseline and at 3-month follow-up. And then also, I won't spend too much time here, but thinking a little bit about the project timeline. So this is a 3-year study that, like I said, will be starting up in July. So starting very soon, and starting kind of with aim 1 and then moving throughout as the 3 years continue. And so wrapping up a little bit here and thinking about kind of the innovation of the project, we know that this is the first alcohol use disorder and suicide prevention intervention in Africa. And so despite that 10% lifetime suicide risk that we saw earlier, no prior study, to the best of our knowledge, has targeted this comorbidity in Tanzania or anywhere else in Africa specifically. We also know that there's innovation and we think about the telehealth and task sharing aspects of the work. And so when we think about the provider shortages of the area, combined with that we know about 90% of folks in Tanzania own mobile phones, and previous work has found that diploma level nurses are very capable of delivering the intervention and kind of sharing some of this task sharing, taking some of the responsibilities away from the psychiatry department and being able to deliver those tasks to nurses at KCMC. And then finally, we know that this is a scalable blueprint for global low resource settings. And so we know that, comorbid alcohol use disorder and suicidal thoughts is not unique to this setting specifically. And we can think about how this adaptation of this model can apply to other settings, like folks in the rural United States with limited access to mental health services or alcohol use disorder treatment services, as well as other LMICs with limited mental health infrastructure. And so a bit of a summary here. We know that Tanzania faces a critical intersection of alcohol use disorder, suicide risk, and treatment scarcity. The IDEAS alcohol use disorder intervention adapts the MI Safe Cope for a Tanzanian emergency department context via this IAM-ADAPT framework. And there's 3 aims. So the first one being those in-depth interviews to identify the drivers of suicide risk. The second one being that co-design adaptation of the intervention itself. And the third one being the actual pilot of the intervention. Upon completion of the project, we will have an IDEAS-AUD manual, pilot data, experimental protocol, as well as a local team to support the future implementation of an R01 hybrid effectiveness trial. And so I will go ahead and stop there and open up anything to questions or discussion. Particularly curious for folks who are from folks from the Tanzanian team about thoughts that you might have regarding this context, the integration of suicide and alcohol use disorder treatment and intervention within the setting, and then any additional cultural considerations that we might want to consider as well as we move forward.
Awesome. Thanks, Maddie. Questions or comments, as she said. I just wanted to flag in case anybody doesn't monitor the chat. I did put in a couple of interesting papers from so you can see this is an area where the folks who are really experienced in this area of alcohol research in Tanzania are coming together with the folks that are more experienced in the mental health and suicide prevention research. So some of the papers from the suicide prevention side, I dropped in the paper that are quite interesting for the context. Questions, comments, observations, thoughts?
Hi, Madeline. Congratulations for the work. I really w- appreciate all this work because was so I don't know, but was so curious to me and how this research could um, help in Tanzania because I didn't know that in suicidal behavior was criminalized in Tanzania, and this was a shock to me because my ask my question is about this, how this will work in your project, because if is a criminalized thing, how work the approach in the emergency room, because sometimes the stigma and around this topic could be more difficult than in other countries. And other thing that I was thinking about is how could have, because in the suicidal behavior, one thing that we ever ask for our patients is about her relationship with the families and friends. And when we're talking about something that could be a crime, is it's really hard to expect then the patient share these feelings with her friends and and family, and how you could, or how you are trying to know these things in your project, and how you management these things, because the first thing that I see in when I see is a crime was, oh God, this work is so much difficult than could possible be in other countries, you know.
Yeah, no, thanks, Bruna. I appreciate that question, and then also someone's discussion around that too. And I think specifically, I know that because of that, we know that or we assume that there's likely a lot of underreporting of mental health challenges, and specifically related to suicidal thoughts. I was hoping some more of the Tanzania folks would be on this call today, because I'm also fairly new to this project, and have been curious about, how, yeah, what I guess what criminalized means within the Tanzanian context in terms of suicidal thinking and suicidal thoughts, and kind of what that looks like. I know that Dr. Knedel and his team oh, go ahead, Ashley. Do you have context there?
Just a little, and I don't want to, don't let me speak for anybody with more experience, or if anybody wants to correct my understanding and assumptions, please do so. But my understanding is that it's true that it's criminalized. However, things would be in other settings, there is some patient confidentiality. So if it is disclosed in the healthcare setting that there are suicidal thoughts or suicide attempt, um, that's the healthcare workers are not like required to report that, even though it's a criminal behavior, legally speaking. Somebody will fact check me if I've got that wrong. But of course, just that alone, the fact that it's illegal does just create that stigma where people might not know, might not believe or trust that that confidentiality is going to be maintained. Um, but I will also add that, and Maddie's totally right. There's, because of that, both for alcohol use and um, suicidal thoughts and behavior, um, uh, there's going to be underreporting. We assume that. However, in our PRACT trial, which didn't seek to do anything about suicidality, we did find a pretty significant number of participants who were either, screened positive for potential alcohol use disorder or had some pretty serious risk factors like alcohol-related injuries. We had, I think it was almost 10% of patients in that sample who reported either specifically there's an item that asks about suicidal thoughts or behavior. So that tells us that at least some segment of the population is endorsing these things despite the stigma. So I think that's a good sign that we'll find people who are needing the intervention and going to say something. I'm glad that Baraka's here. I'm going to kind of turn it back to because I see his comment in the thought. He has a correction about psychiatrists at KCMC saying there's currently about approximately 5 working at KCMC. So we're going in the right direction. I know when I started doing this work, there was one who one was finishing training. So a lot of progress has been made just in the last 10 years.
Yeah, thanks, Brooke. That's good to know because I took that number from the grant, so I'll make sure I make a note of that as well. And then I also see the comment from Eduardo about nurses conducting the sessions and if they're normally trained to address complex mental health issues. And so I'm not 100% sure on the context of whether, what kind of training looks like for nurses within their coursework or kind of diploma programs specifically, but I do know that Dr. Knedel has done a lot of work in developing the team as part of his Ideas for Hope project that really focused on this task sharing aspect of the work of being able to share some of these responsibilities, with there being, only a handful of psychiatrists working at KCMC, who also, I believe, oversee some of the work that happens at the Moenzi local hospital, which has some of the only inpatient beds within the region. And so there's just a lot of work for them and they stay very busy. And so as part of his Ideas for Hope project, I know that was a big component of the work of task sharing this over to nurses, which they had found had been successful. And I do think as part of the intervention, they receive quite a bit of extra training in addressing some of these, more stigmatized and sensitive topics within the population. And I think part of that will also come out as part of the intervention kind of adaptation of thinking about what additional kind of training is needed for those nurses to be able to specifically tailor the intervention to folks with that comorbid alcohol use disorder and suicidal behavior, suicidal thoughts. And so I think we will learn more about, additional training as well. But from formative work in previous studies, we have found that the nurses have really done a great job and hold all the expertise to be able to deliver the telehealth intervention.
Mm-hmm. Other questions, thoughts, insights?
Based on your experience with Brecht so far, what do you think the main challenges will be on this methodologically?
From a method standpoint,
Yeah.
So I know that I've read that we have had pretty good follow-up, and so I know that's usually generally a concern when we think about missing data. But it looks like within, old, like the PPK studies and other studies that have been conducted at KCMC, I think they've had like 83 to 100% follow-up, depending on the study of what I've read. And then I think other methodological challenges that I think about is potentially, still that kind of like under reporting, and whether we're underestimating kind of the actual effect of the intervention or thinking about kind of the social desirability bias that could occur when we think about how folks answer the instruments And so ensuring, that folks feel comfortable and in a confidential space, I think would be helpful with that as well. Do you have, I'm curious, Rob, from your standpoint of what you think about when you think about analysis and potential methodological challenges as well?
Yeah, I think we're never really prepared to do this work with the proper assessment on the quality of the outcomes, which ends up messing up the entire design. So the more I work with designing studies, the more I see how the 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 preliminary work that's needed for you to properly design a study is not done, and most times because of funding constraints, time, and I think it's something we have to start taking more seriously. So even here on ideas, we did the best we could, but if you think about the main outcome measures, I don't think they're properly validated in the setting. Even with our measures of depression, the audit, all of those things, we continuously have problems and find problems with translation, even doing the whole work. So the quality of the measurements, I think it's a problem. There's now the whole discussion you were seeing about stigma in this population. So I think it would be very fair to assume underreporting. So the quality of our screening, I think, will be limited. And I don't think that there's been any proper study done in Tanzania showing how good screening is with the proper anchors. It's also hard to do for this case, but still. So I think it's okay to say anybody that within a stigmatized community endorses any level of suicidal thinking should be of concern. So I would agree with that. But then I'm also concerned with something that we saw recently on looking at the drink scales. I think Rafael is not here, has been looking on the drink questions, and the drink survey has embedded on it some questions that are validation questions, so questions that you would necessarily expect people to answer no to because they're like dumb or whatever. And we've noticed that there is a good endorsement of those questions. So it makes me think how much the comprehension of the questionnaires, or just how much of the I'll answer whatever it takes to get this over with because there's money tied to it. So, or for whatever reason they are answering the questionnaire. So there's something around the self-report that I don't think we've done the thorough work behind it as a whole, usually because there's no funding around it and it's hard to do. So it would be student-led work, but then students got to be interested on it, and it's methodological work. Most students don't really want to do it. So it's tricky. And then on the other side of the whole thing is how then you design a study that will give you enough evidence to make good assumptions for your power calculations in the trial afterwards. Like we also don't have any of those. Like now with PRACT, I think we have a very good understanding of alcohol during the trial. But as we went into PRACT, we went in flying very blind on some things based on literature, which was not from Tanzania, very different from Tanzania, with some preliminary work we have done, but it's the volume of work in these areas, especially because of the stigma, are not always great. And you learn as you go, and you learn by you do it. But I think that's going to be a big challenge here. So in overall, there are important challenges, and then there's fidelity challenges, which I think we should, as a preparation for ideas and for price, spend a decent amount of time reflecting on fidelity problems with PRACT and understanding what those are, how do we fix it, how it impacted the data we pulled out of the trial. So just things that I think we need time to reflect on, and the US model of science don't give you time. You got to keep moving. And usually I think it's not great. Yeah, so that's my reasoning around it. So to make good decisions, I think we need to spend a lot of time thinking about them.
Yeah. Yeah, thanks, Joao. And I did make a note about how the pilot study is really just served as like a feasibility study to enhance the likelihood of success of an RCT, but that it's not adequately powered. And so how do you think about, I guess, when you go to power an RCT, like how do you use, I guess, this like pilot data or feasibility study to know whether you have enough evidence to inform an RCT?
Yeah, you almost never will have enough evidence, because
Okay.
if you have the answer, you would have the answer. You wouldn't need the RCT for. But there's some pieces of the puzzle you can get answers for. So while you, in a feasibility study, you can't power for the effect, you can power for the evaluation of the phenomena. So one thing is, if we're going to measure depression, what is the baseline prevalence of depression in this population? And then let's look at that population. Let's compare a population that have a depressed diagnosis to a population that doesn't have a depressed diagnosis. And let's look at the difference in the scales and maybe use that as a target for our power calculation. So there are some things you can do and you can power for, even in a feasibility version of the study. I just don't think we usually put our attention to it. We think a lot about the intervention. How is the intervention going to be helpful? But there's trialability aspects of the implementation pipeline that I think we usually rush through. And then on my perspective, I think the assessments we have for mental health and depression and all that are all completely biased in Tanzania, just for language barriers. And that I've been having conversations with Kim about this for a while now. But then how do you study that? Like we got to get students interested on this to do the preliminary work that's needed on this kind of thing. I think Ashley is speaking, but there's no sound.
Sorry. Yes, I want to expound a little bit about this, address some of the things that Joao said, some of the questions that have been raised so far. And first off, give a caveat, which I...
No, we lost you again.
how about now? I want to give the caveat up front that I should have given, which is that Maddie has been working with us again for like a week, and she agreed to do this presentation after just getting a rough understanding of the project, which is just starting and subject to change a little bit. So thank you, Maddie, for doing that. And just to give her the out, if you don't have the confidence to answer a lot of these questions, that's totally fair. So one thing I want to point out is, it is good. Joao's points are right, and especially don't want to miss that he's talking about, in particular, the like validation and testing of these outcome measures, which is a hill that he will die on, I think, one day. But I think the nice thing is this is an R34 project, which is a grant mechanism that's designed for planning for larger projects. So it's great that NIH is willing to fund these things. This is the same kind of thing we're doing with Price right now, where it's sort of an in-between. We have some preliminary evidence. We'd like to do a big hybrid trial later. Let's do the groundwork we need now. So I think it could be incorporated into the AIM-3 or even or as a sub-study or supplement or something to do more, to explicitly say we want to do more of this outcome validation, which would be great. So that's one point. Another point that I'll give credit to my third point. Oh,
we keep losing you for some reason. I don't know why.
Sorry. So
it's the internet. Do you want to turn the mic on your computer, maybe?
I don't think that's going to help.
The mic is fine. Maybe you're getting out of the zone where the microphone is getting your information. Maybe.
Maybe the microphone is too good. We've had some problems with our audio outcoming. So regaining my train of thought. I wanted to give credit to Kayla for a question that she raised, which I don't think, Maddie, you might not have the answer to, but if you want to say something, feel free, is what about cases where, you know, we talk about social support, and in the PPK intervention, the existing alcohol intervention that we have in Tanzania, we encourage people to use, you know, positive supporters, trusted friends or family or clergy or something to turn to for these needs. But we know, and I've heard, you know, anecdotally that that's not the case in every patient. And perhaps that's causing or exacerbating some of these symptoms and challenges. You know, it could be some kind of cycle where people are being ostracized, and so then they're continuing that. So that's something to keep in mind. I'm wondering about that paper that I shared in the chat that Ryan Parker is the first author on, which is the role of faith in suicide prevention among people living with HIV, perspectives of religious leaders and mental health workers in Tanzania. I'm wondering if that has some insight where maybe the proposal is that those are the people to fill that gap. Did you want to add something else?
They hear me? You guys hear me?
Come closer.
Yes, we can hear.
Thanks.
So that was my point, but also like to piggyback off of what Ashley said, because suicidal or ideology is criminalized in Tanzania. I feel like that, like when you look at like family values, that stigma could cause them to distance themselves for their family or be shunned out of their family and become the black sheep, driving them to that. And cultural differences and family differences are different amongst countries, I would say, like Tanzania and Africa, they have like strong familial ties. America, it's a little dysfunctional, I would say, more so. So, like, how would you account for that? And also because they might have distanced themselves from their families can't exactly give an honest report or all-knowing report of like how to best assist. Or they might not be honest because they still face the criminalization or they are associated with the criminalization of the suicide and stuff.
Yeah. No, thanks, Kayla. That's a great point. And I think it's interesting too when we think about like the comorbid piece of the alcohol use disorder and how some of those like sociocultural kind of perspectives play into it as well. I know work that Elena did for her master's thesis and as part of the PPK trial found a lot of, especially when we think about like gender and gender differences between some of those social and cultural kind of consequences of alcohol use. And so how we think about, you know, how women might experience both alcohol use disorder and then potential suicidal thoughts or ideation versus men of, you know, alcohol use in general for women is already much more stigmatized than it is for men. And so does that, you know, push women to potentially more greater mental health challenges, and when we think about more suicidal ideation or thoughts, and then because it's so stigmatized as well, you know, with suicide in general, mental health among men generally globally, do we see more of that like underreporting among men? I don't know. I think those are just things that I think about that could be interesting that sit at this intersection of the work.
And then just one other point that, go ahead, Joao.
No, go ahead.
Well, I'm going to shift the subject just slightly, but we can go back to that if you like. One other thing that this thought brings me to is the support. We're talking about social support for the patients and their families, but the support for staff. I might have brought this up to you, Maddie, before, but this really heavy for the staff that deal with this. Maybe particularly our clinicians, especially those working in the realm of mental health or emergency medicine, who face a lot of these challenges in the day-to-day, have more resilience and experience, but especially for staff who are maybe collecting this data or talking to patients face to face. We know that these topics can be really challenging. So I trust and I think we'll have to work with some of our experiences from both Brandon and Kim there but also some of our other research groups. I know, for example, Charla, as we mentioned in some recent meetings on some of the perinatal loss work, has had to kind of have a protocol, not only for dealing with patient crises, but debriefing and supporting our staff who are facing these difficult topics, especially when they're seeing these cases like Caleb proposes as a hypothetical, where, the underlying basis of this study, of this work, is that there's a lack of services, there's a lack of support. So you can imagine how difficult that is when the patient is in front of you telling you that they're at their wits' end at a crisis, but you don't have resources to offer them, or you have very limited or inaccessible resources. That's very difficult for the psyche of the person themselves and the recognize, and we'll have to be very intentional about making sure we're supporting everybody involved in the project. Did you want to add, Joao?
No, I think you got a good answer. I was gonna add that I know this suicide being a crime can generate stigma. I'm curious how much people know that that's a crime and how much that is embedded in the culture, and if they do think about it as a crime, or is it more like a moral offense in their perspective, and the stigma is much more on this moral side. And then I won't go into it, but I think the fact that there's a very strong Catholic presence there creates more hurdles around this as well, in terms of this moral aspect versus the crime aspect necessarily. So I'm just curious. So for me, I don't know all those things. I'm hoping we can shed some light into some of these elements in this feasibility study, especially around alcohol. Yeah.
I'd love to hear, I don't know, Baraka, if you're with us, or others who have feel free to add if you have any thoughts or insights.
Hi, Ashley.
Karibu.
I don't have further comments on this. Thank you.
Thanks, Baraka.
Cool. All right. Well, lots of interesting challenges we're gonna have to address on this project.
Can I ask something very apart from the topic, but have you ever used, and what results did you get with for adapting instruments, the use of cognitive interview? Did you use that? What do you get any results of that?
Oh, Marcella, yeah, we have. We've done it individually, we've done it in groups, we've done it guided by Tanzanian research assistants, we've done it with me in the room, trying to see if I could grasp troubles of comprehension in Swahili. We've done it with psychiatrists leading the conversation. And in the end, there's always small nuance to the words that are used that 10 years later, our team is still debating if we're using the right word or not. And those nuances come because people comprehension is different, but it's in a sense that it changes the meaning. So if it's like in Portuguese, if I use a synonym of a verb, it doesn't necessarily change the meaning. But in Swahili, because you're trying to translate complex Western concepts into a non-Western language that don't use the same structure, they change. So the example that I think was the most shocking one was that when we were translating the audit, there was one question in the audit, I think it's question number 10, where the question is, have your drinking, look at the phrasing of the question, is terrible. I would love to go to Jeremy and the audit people and say, you guys really made a bad job of this. But Does your drinking has caused problem to someone else? And the meaning behind this is the fact that you drink and being drunk or spending money. There's so many aspects to your drinking behavior. Has that caused something to someone else? What could be directly causing, could be indirectly causing. There's so many nuance to that question. The first translation we managed to get from Tanzania translated in a way that the sentence was, has your drinking caused an injury to someone else? Or have you caused something to someone else because of your drinking? Now it puts the agency in the person. So it's not now something around, has your drinking impacted your behavior in whatever way possible? It's really, have you caused something to someone else?
Mhm.
And that now it brings moral value, it brings agency, it brings intent. And so after years collecting this data and after done several rounds of translations, one day we were looking at the data and we just noticed that this particular question had just very, very small endorsement. Well, for us, it was like, it doesn't make any sense because there's people with a very high audit, but very low endorsement on this. It went on, and then after a lot of discussion, we finally managed to understand our team explaining what that meant in English and noticed the nuance. And so that, now imagine you trying to do that for alcohol, which is more widespread and it's not a lot of concepts embedded on it. But now try to do it for depression, which doesn't even exist as a meaning. Like there's, depression is a diagnostic that is attributed to the health professionals, and there's a word that was created for it, but it's a word that people don't understand because the concept of depression hasn't been embedded in the culture as much as depression means the same thing as just having a mental problem. And so depression could be the same as anxiety, could be the same as could be the same as
Stress.
so all the questions in the PHQ-9 that end up focusing on this, the PHQ-9 then asks several symptoms of depression that in Swahili, it's all the same word. So are you upset? Do you feel sad? Do you feel, and we couldn't find good definitions for it. So it's not a matter about just adapting the language. We have to adapt the concept. Maybe even creating a new variation of the scale. But yeah,
Almost a new scale altogether, right?
Almost. Well, because the point too is that these scales in English aren't exactly that easy to answer sometimes, like in other languages, because the items themselves are a little bit odd. Another one that comes to mind is what I was talking about that came up when we've done these group cognitive interviewing sessions is that is the one about feeling bad about yourself or that you're a failure or who have let your family down. And it points out, this one to me pointed out how much it's important to need specialists involved in these conversations, not just people who are good at the language, but who understand underneath the hood what these items are getting at. Because, for example, I think I threw out like, oh, you're a failure. If I'm going to reword that as a layperson, but a psychologist would say, no, that's exactly what we're looking at is for people with depression believe they're a failure even if they haven't failed, right? So there's these subtleties that are really difficult to translate in any language to make them more simple from language A to language A simpler. But when we're doing across cultures and across languages, as Joao was suggesting, it becomes even more difficult.
Yeah, what I'm more concerned about is that if the words in the meaning doesn't exist in the language, then this phenomena, this experience is expressed some way that is not necessarily translated to the same symptoms, because you don't really feel what you can't verbalize. So you feel it in a different way and you verbalize in a different way. And so what Kim has been arguing is that in African men that he has more experience and data on, depression is expressed as behavior and as motor inactivation. So depressed men work less, have harder time doing activities, engage less on day-to-day activities, things that we don't really explore a lot in the PHQ-9, because the PHQ-9 assumes people are able to frame their feeling as sadness, as upset, as a sense of failure. And that doesn't necessarily represent. So, and then that all translates into all the work we've done in trying to establish cutoff points for PHQ-9 in some East African communities. They all come back into giving us a cutoff of 3, 4, 5, where the accepted one is 10. And for me, that's because people don't endorse anything, because nothing's happening to them. It doesn't make sense. So you end up having less score separating depressed from non-depressed, which is a problem in the scale for me.
Yeah, good points. All right, I think we'll have to end our discussion there because we're out of time. But if you guys have other thoughts, feedback, please feel free to get in touch with Maddie or the leaders of the project who you heard her mention. But join me in thanking Madeline for a great presentation today and lots of interesting points for discussing. We'll see you all next week.
Thanks, everyone.